Some of the things I'm going to talk about, I'm a little bit doubled over, but hopefully I have some unique points to add. These are my declarations. So I'm really going to talk about my top 5 reasons why robots do not currently have a place in my clinical practice. Reason number 1, as we've seen already, no data exists suggesting that using robotic surgery will make my patients more satisfied or reduce my revision risk. We've already seen this fantastic 10-year follow-up paper from Korea presented and discussed earlier by Jung Kong Sion. Single surgeon, 700 total knees in each group, mean 13-year follow-up, mechanically aligned robot versus conventional, no difference in either functional outcomes, loosening, overall survivorship, and complications. Number 2, I live in a country that is currently in an economic recession, with its resultant sustainability and healthcare issues moving forward. You look at all of our countries here, just plotting our GDP growth versus increasing cost in real health expenditure. Australia is above the line, but in fact, every other country there is above the line. And if I mark out some of our panelists, all of our panelist countries are above the line, i.e. that we're spending more on our GDP can support. And if COVID is just going to make this worse, I've marked Australia here, we're going to probably have between a 5 and 6% reduction next year. And every other country is going to have the same, some worse than expected. I've just circled some of the countries here that are represented by their panelists. Theatre time is expensive, as we've heard. In fact, this 10-year study I mentioned earlier from Seoul, 28 minutes extra. Now, let's assume it's an old machine, but if I extrapolated that into my volume, that's 140 hours extra time in the operating theatre for the same TCAR volume, representing over $500,000 Australian dollars per year in extra cost. And that's just not taking into the costs of buying the robot, the software, etc. And in fact, some studies suggest increased costs by 26%, 10% of total knees in Australia now robotic. This represents an additional $65 million per year in Australia currently in a strangled economic environment. Number 3, as we've heard, increased reliance on complex technologies result in automation complacency. This is well recognized in the aviation industry. The poor detection of system malfunctions under automation compared with manual control results in errors. There's 2 types of errors: complacency to performance bias. So there's a performance bias error, or complacency to data error bias. Just because the robot says it's right or is doing it doesn't mean it's correct. Number 4, every total knee replacement I've ever performed is being tracked in a registry, as David Parker mentioned. And in Australia, this is data from the Australian Joint Replacement Registry. Look at revision risk for individual surgeons. Each dot is a surgeon compared to total number of procedures. When you look at all surgeons, all prosthesis, there's a significant proportion who are outside the 99.7% confidence limits. But if you take away all the high-risk prosthesis and just look at the lower-risk ones, the vast majority of those outliers disappear. So performance of outcome long-term is actually based around prosthesis selection, and we've published this in KISTA. 2 years ago, we looked at what's a low-risk prosthesis, and it's mainly not the brand, but the style. It's a minimally stabilized, fixed bearing, cemented tibia, cross-linked poly with a resurfaced patella, and that decreased risk by 60% compared to the rest. Or if you use something else, it increased your risk by 150% or greater. So prosthesis selection is far more important than the robot or how you align it as such. However, it's not very exciting to talk about. It's difficult to excite people about boring prosthesis selection. Number 5, no one agrees how to optimally align or balance a total knee. So why would even more precision be of any benefit? It's the accuracy versus precision. The question is, what is our target? I argue we're not even looking at it the correct. It's probably not even in the room. Soft tissue releases are not detrimental to our patients. So why are we so focused on avoiding them? So in conclusion, Heinrich Malkart talked about a stepwise introduction to new technologies. Initial step, prospective randomized studies, multi-center studies, and then registry studies. I'd argue that we have a different situation currently. We have multinational orthopedic company buys new unproven technology. Same company recruits Coles to that new technology, then commences an advertising campaign, and then competitor multinational orthopedic companies buy similar, but again, unproven technologies, recruit their Coles, and then commence their own advertising campaigns. I'm sure in 2020, we can find a better way. So robots do not currently have a place in my clinical practice because they're very expensive, no evidence of any clinical benefit, and we are facing an increasingly non-sustainable healthcare environment. However, they're a fantastic marketing tool, as David Parker suggested, and an interesting research device as well. Thank you.